Dr. Justin, when you are ready, let me know.
We can start.
Yes, Ajit, we can start. I think there are 60 participants. Yeah.
Yes, so we'll start. Yeah. So good evening, friends. We, on behalf of the Bangalore Intensive Care team, Indian Society of Critical Care Medicine Bangalore chapter, we welcome you all for the second PROCON debate today, and we have excellent speakers here. You know that there was unfortunate news we all heard this afternoon. There was a sudden, untimely, demise of a 46-year-old superstar actor, Mr. Puneet Rajkumar, because he was just, I was told that he was having some kind of exercise, gymming at home, and he had a sudden massive cardiac arrest, and he was, unfortunately, is no more now. So before we start the session, we just want to give a quick tribute to the departed soul of Puneet Kumar. We'll make a silence prayer for around 15 seconds before we go to the session. So we'll just start the silent prayer now.
Dr. Ajit, I think, is having some internet issue. We can, Dr. Justin.
Good evening, one and all. I think until Dr. Ajit Kumar logs in, and I will probably take a minute to introduce both of the speakers of the first PROCON debate. Dr. Pankaj Anand, who hails from Jaipur. He has been, for the last 2 decades, has been a senior clinician working in the fields of pulmonology and intensive care. And he is a member of multiple societies, including emergency medicine. And he has a vast clinical expertise, and he will undertake a PROCON debate against Dr. Ravi Mehta, who is a well-known interventional pulmonologist from Bangalore. and Apollo hospitals. And I think Bangalore Intensive Care Society knows him well enough that he doesn't need any further introduction. May I request the participants to start the PROCON debate, and I think Dr. Pankaj Anand going first.
Can I start,
Yeah.
sir?
Yes, please go ahead, Dr. Pankaj Anand.
Yeah. Just give me a second. Good evening, everyone, and a very warm welcome. Let me first thank the Bangalore Intensive Care Group, the organizers, especially Dr. Ajit, for giving me this opportunity to come and present my case. Thanks, Dr. Justin, for your introduction. A big thank you to my opponent, Dr. Ravindra, for agreeing to come and speak against me. For a very because he has dared to speak against a very obvious topic. We're going to debate the prophylactic and therapeutic use of antifibrotic agents in COVID-19 related fibrosis. Frankly, it is as useful as any other therapy that we've tried in this menace. We all know that we face this catastrophe of the pandemic where billions of people got infected and we lost lakhs of people. Besides the acute loss of lives, there have been what we call the long haulers. Increasingly, number of patients who survived COVID-19 continue to battle the symptoms of the illness long after they have been clinically tested negative for the disease. Now, there has been the acute phase of pandemic, which involved millions, I would say billions of people. These are the waves that we've seen: first, second, third, and fourth in some parts of the world. Majority of people, almost 95% of them, had moderate symptoms, while 5% had severe to critical illness, of which almost half recovered. Unfortunately, we lost around 20% of the severely ill, and the remaining around 30 to 50% of the severely sick patients still are suffering from long-term sequelae, including pulmonary fibrosis. So over the next 8 to 10 minutes, I'll try to lay a background of what we are going to discuss today, especially in terms of fibrosis. You know, when we probe the long-term sequelae of COVID-19, we have to remember that there is limited peer-reviewed data which is focusing on the occurrence or prevalence of COVID-19 related long-term sequelae. Now, it is reasonable to anticipate manifestations based on our knowledge of the pathophysiology of COVID and our experience with other coronavirus infection outcomes. The major organs which are involved in the long-term sequelae obviously are the nervous system, the cardiovascular system, and of course, the lungs. Now, among patients who are recovering or have recovered from severe COVID, impaired diffusing capacity for carbon monoxide and exercise capacity is common during the first 6 months following discharge. We know that severe COVID is not just the disease of the lung, it involves the entire body. But unfortunately, lungs are the worst victims. There is diffuse alveolar damage. Autopsy has proven that platelet fibrin thrombi basically hint towards a coagulopathy. About 5 to 10% of these patients develop severe COVID-19 related pneumonia and ARDS. Majority resolve without residual lung damage, but the sheer number or the sheer size of the disease actually results in sizable number of patients who are likely to develop post-COVID lung fibrosis. Now, there are various mechanisms of lung injury, including both viral and immune-mediated mechanisms. Fibrosis occurs largely due to a disorder in the wound healing process and may be directly related to the severity of the inciting event or the duration of the event. Now, if you look at this prevalence, in this cohort of around 159 autopsies from COVID patients with ARDS published in the Experimental and Therapeutic Medicine, fibrosis was reported in 4% of patients who had a disease duration of less than 1 week, 1/4 of patients with a disease duration of between 1 to 3 weeks, and almost 60% of patients who had a disease which was longer than 3 weeks. So almost 1 in 3 of the recovered patients of severe COVID-19 pneumonia had some form of fibrotic element involved in their lungs. Now, this review in the American Journal of Physiology laid out the cellular and molecular mechanism of viral injury. We need not go into it, but it was a virally activated pathway which led to cell injury and response, inflammation, which led to mechanical injury. Most of these patients, as I said earlier, recovered, but some of them had a stable or progressive fibrosis. Now, if you look at the mechanism associated with the viral infection that could lead to fibrosis, these mechanisms include viral activation of the pro-fibrotic pathways in the form of altered renin-angiotensin system balance, inhibition of post-translation, activation of growth factors like FGF, EGF, TGF-beta, and a rearrangement of the cytoskeleton. There could be direct cellular injury, mainly involving the type 2 alveolar epithelial cells, the macrophages, and the endothelial cells. There could be a cytokine-induced injury. We know ARDS, immune recruitment, or an aberration in the response, the wound healing response. There could be a mechanical injury in the form of volutrauma, atelectotrauma, barotrauma, or biotrauma. And then there could be the sheer age could affect in the form of an alteration in the cellular communication, exhaustion of the stem cells, or a dysregulation of the extracellular matrix. So we all know the risk factors: smoking, chronic alcoholism, and advanced age, a more severe disease with associated comorbidities, a longer stay in the ICU and mechanical ventilation, and increased level of inflammatory markers. All of them make the patient at a higher risk of ultimately developing pulmonary fibrosis. Now, if you look at the predictors of pulmonary fibrosis, there could be clinical and lab predictors, as I said: older age, increased acute phase reactants, longer term of hospitalization. What is the HRCT imaging saying? So if a patient has an interstitial thickening or an irregular interface or post-reticular pattern and a parenchymal band, then chances are that this person will have higher chances of pulmonary fibrosis. Similarly, an advanced disease in the form of more segments of the lungs getting involved and larger lesion diameter could also predict a worse prognosis. Now, when we talk about the natural history of post-COVID lung fibrosis, I think it is still early days to talk about the natural history, because we are still getting a lot of patients who have suffered from the disease till very recent times. And in fact, many parts of our country still are getting bad COVID infections. But this Zhang et al. Did a follow-up imaging after a median of around 11.6 days in 42 COVID-19 survivors. And they showed evidence of progression almost in 80% with progressive opacifications, thickening of the interstitium, and fibrous strips. They also mentioned that the severity of opacification assessed in the initial CT was directly proportional to the final CT findings in the follow-up CTs. A recent autopsy by Shevinson said that pulmonary fibrosis, including large areas of disruptive architecture with fibromuscular organisms and collagenized fibrosis, is pretty common in these patients. And the honeycombing and remodeling that is seen in the CT is very similar to that seen in other forms of ILD, especially the idiopathic pulmonary fibrosis. So still, if you want to talk about natural history, as I said earlier, most commonly the patients improve. Patients who show initial fibrosis and are static are less common, and the least common are the patients who have progressive fibrosis. But these are also the patients who will probably benefit the maximum with antifibrotic therapy. Now, if you think about or discuss the chest imaging features, and that's interesting: traction bronchiectasis, architectural distortion, loss of lung volume, and septal thickening. All findings are almost similar to those seen in other fibrotic diseases like idiopathic pulmonary fibrosis and other ILDs. Therefore, at least presentation-wise, you find a lot of similarities between acute exacerbation of IPF and a bad COVID fibrosis. So let me move to the treatment. Three complementary strategies are known to reduce the likelihood of development of lung fibrosis, depending on what stage the patient comes to us. So if the patient comes in the acute COVID pneumonia, the antiviral therapies are postulated to be beneficial in preventing further fibrosis. In the evolutive COVID-19 pneumonia, it is the anti-inflammatory and the antifibrotic therapy that might help. Steroids, of course, are the most commonly prescribed drugs, especially in post-COVID fibrosis. They should be continued on discharge if the CT scan prior to discharge continues to show significant ground glass opacities and the patient remains hypoxic. There are critical points of reciprocal influence for COVID-19 and IPF. I just want your attention here. Antifibrotic medication in acute exacerbations of IPF are definitely, they reduce the acute exacerbation and they are known to reduce mortality. Remember, the antifibrotic medications were designed to be useful in IPF. When used in COVID-19, they are known to modulate inflammation, they prevent ARDS, they reduce post-ARDS fibrosis. Now let me move to the antifibrotics. Antifibrotics are known to be useful in patients with acute exacerbations of ILD, especially IPF and other fibrotic ILDs. And we know that the fibrosis with fibroblasts and honeycombing has clearly now been demonstrated even with patients of COVID-19 related fibrosis. So the excessive inflammatory state, which is associated with the presence of fibrotic tissue induced by COVID, has been shown to play a key role in the clinical presentation of these patients. And the use of agents to prevent or reduce fibrotic status, for example, pirfenidone, may be therapeutically effective in preventing serious or fatal complication. Now, we know that pirfenidone is a drug of choice in the treatment of IPF and has a pleiotropic mechanism of action that I'll discuss. It is known to inhibit apoptosis, it downregulates ACE receptor expressions, it decreases inflammation by several mechanisms, and it ameliorates oxidative stress. Therefore, pirfenidone protects pneumocytes and other cells from COVID-19 invasion and cytokine storm simultaneously. So it can be a safe add-on to the current protocols of COVID-19 treatment with little side effects and a lot of potential benefits. Now, how does pirfenidone act? It has an anti-inflammatory effect, which is by inhibition of the TNF-alpha secretion and decreasing the large number of other inflammatory cytokines. It ameliorates the lipopolysaccharide-induced pulmonary inflammation and fibrosis, mainly by blocking the NLRP3 inflammasome activation. Coming to the antifibrotic effects of pirfenidone, it inhibits the TGF-beta, which is the main culprit in COVID fibrosis. It downregulates the pro-fibrotic gene expression and collagen secretion, collagen I fibril formation, and it also causes a reduction in the collagen fibrin bundles. It has pleomorphic actions on the immune system and extracellular matrix and regulates tissue injury and repair. Another molecule that most of us know about, if we are not used, is nintedanib, which is known to improve pulmonary fibrosis, largely by inhibiting the action of PDGF, FGF2, and the vascular endothelial growth factors. It also has been known to shorten the length of mechanical ventilation. Now, there's another promising group of molecules, the so-called histone deacetylase inhibitors. It is a promising strategy to combat pulmonary fibrosis, promoted mainly by TGF-beta signaling in the COVID-19 survivors. So HDACs are reported to play a prime role in regulating intermediates of TGF-beta signaling pathway. Remember, TGF-beta is said to be the main culprit in fibrosis because of COVID. Increased expression of HDACs has been shown to prompt or trigger fibroblast differentiation to myofibroblasts and in turn increased ECM formation. So these HDAC inhibitors have different names. Probably in times to come, you'll hear more of them. Vorinostat, promidepsin, trichostatin A, you can go on with the names, largely been found to be useful in IPF. We have to remember that early intervention with strategic treatments such as HDAC inhibitors addressing the secondary or late results of COVID infection will help reduce complications and mortality and provide better quality of life for the COVID-19 recovered patients. Ladies and gentlemen, this was what I wanted to talk about, in the sense the basic theory, where we come from, what is the role of antifibrotics in COVID-19 related fibrosis. Now, let me just get deeper into the subject itself, and what better way than to present a small case history. Now, this, let me tell you, I have not treated this patient. This is the way an average patient of COVID pneumonia has been treated in our country. I'm not giving any value judgments. You might like it or not. So this was a 36-year-old lady, had fever, cough, generalized body pain for the previous 3 days. She went to her GP, was tested RT-PCR positive for COVID-19 and was home isolated. In isolation, she panicked and took consultation from anybody and everybody, and a lot of clinicians got involved. So she received favipiravir, ivermectin, doxycycline, zinc, vitamin C, vitamin D. I'm not over exaggerating. I've seen this prescription. Unfortunately, none of them worked. Her respiration worsened on day 4. She became short of breath, had extreme fatigue. Her blood reports showed pretty high D-dimer levels, C-reactive protein and LDH, and a moderately raised IL-6. A CT scan done that day had a CT severity score of 18 out of 24. So she got admitted immediately into a hospital and was started on remdesivir, an antibiotic, Medrol, and low molecular weight heparin. She was on oxygen support on non-rebreathing mask. Since her IL-6 levels remained persistently high, the treating doctor gave her 2 shots of tocilizumab at the right interval, and she also received the wonder drug, the deoxy-B glucose. Unfortunately, nothing worked. She had to be intubated for worsening respiratory failure. She also received Mycobacterium W, branded as Sepsivac, and unilastatin. She made slow but gradual progress and was in the hospital for over 1 month. Her CT showed fibrosis just before the discharge. So besides the usual prescription, it also contained the drug Perfenidone 600 milligram thrice. My learned opponent might have some objections to this particular drug being prescribed here. I would just like to bring your attention back. If you don't have evidence for the use of Perfenidone here, then I think the evidence in favor of favipiravir, ivermectin, doxy, vitamin C, vitamin D, remdesivir, tocilizumab, 2D, glucose, Mycobacterium W, unilastatin. Where is the evidence? But I'm not saying that it should be extrapolated in the same way. Remember, this pandemic has been unprecedented in sheer numbers, and we have had no significant clinical experience, most of us, in diagnostics or therapeutic modalities. If you remember the early January 2020, most of us were ventilating our patients as per the routine ARDS protocol. We were trying each and everything. We learned in the process. Remember, a lot of pharmacological modalities were tried for the first time. So there were newer drugs, there were licensed antivirals which were indicated for some other infection. We had experimental antivirals. A lot of people used convalescent plasma, monoclonal antibodies. Therapies proven for other similar disorders were tried in most cases. Some of them had beneficial effects, some of them didn't. We can have, I think, debates for each molecule. Many of these therapies proved to be effective, even though based largely on anecdotal evidence with absence of large RCTs. More or less similar situation is for long-term fibrinolytics, have proven role in fibrotic lung disease like idiopathic lung fibrosis, and the presentation is very much similar to IPF, so there lies the logic. Remember, most therapies have received emergency use approval with very little data. Only proven therapies are oxygen, LMWH, and steroids. My dear friends, desperate times demand desperate measures. We have not had the luxury of enough time to either study, test, interpret, and find novel therapies. The results and experience from proven therapeutic modalities for other similar disorders, like IPF in our case, had to be extrapolated for this disorder. A debate on the effectiveness or otherwise for any, especially for this, is futile unless we have the time or opportunity to prove or disprove. Remember, when you are tasked with saving lives anyhow, you don't waste time and effort debating. Remember, the absence of evidence is not always the evidence of absence. In the times to come, a large number of clinical trials are underway for studying the effectiveness of these molecules, and I'm pretty sure that if Dr. Ajit calls me back for the same debate 3 or 6 months from now, I will then be having a much heavier evidence in my favor as I have today. Remember, the clinical features of COVID-19 fibrosis are shared with acute exacerbation of IPF, therefore the logic of its use. There is therapeutic rationale for the use of licensed antifibrotic therapy for acute exacerbations of IPF in most COVID fibrosis. And available antifibrotic therapies have broad antifibrotic activity, whatever be the etiology, and these drugs have a role in attenuating the pro-fibrotic pathways in SARS-CoV-2 infection. With this, I rest my case. Thank you.
An excellent talk, Dr. Pankaj. Obviously, given the amount of literature available, you brought forward the pathophysiology, and you made a valid case for your pro stance. And I think we will press on you for a few more questions at the end of the session. Maybe I will now request Dr. Rendra Mehta to counter the argument with the use of antifibrotics as a prophylactic or a therapeutic use in COVID-19 in management of potential fibrosis or fibrotic disease. Dr. Rendra Mehta, please go ahead.
Yes, hi. Can you see my screen?
Yes.
Well, thank you very much, Justin, for both calling and the kind introduction, and likewise to Ajit. And Pankaj, it's lovely to see you, and you always your usual erudite and clear self. So unfortunately, we take two sides on this particular issue, and I will try my best to put a contrarian point of view. So I get the con on this particular debate, and this has been going on for a while because, as Pankaj rightly pointed out, I have to agree on at least a few things with him, that it was completely a crazy, chaotic situation and we did not know what to do. So often, as happens in such situations, practice has preceded science. And this is where we have to decide where do we go from now, or what do we have today with us, which at least helps us to take care of our patients now. So today's discussion, this title itself is controversial. If you look at the whole title of Anti-Fibrotics as a prophylactic or therapeutic agent, we'll make a case for why it's a problem. And maybe we should end the debate here itself, because I saw Pankaj making a brave case for a topic which doesn't have much basis, at the same time having a conciliatory tone in the end that, okay, later down the line, maybe he'll have a better leg to stand on, with full credit to him. So here the term post-COVID pulmonary fibrosis, which basically is a problem when we think of the connotation of this term. So let's understand the basics. What is fibrosis? And fibrosis for years has been end stage disease which does not have any scope for restoration. And so by definition, we don't like it, because it actually means a condemning death sentence for either the cell, the organ, or the patient. I went back to Webster's dictionary, sometimes a useful thing to wind beyond your medical years, where it says it's a condition marked by increase of interstitial fibrous tissue. And that is why we have to understand that right from the English aspect to the medical aspect, lung scarred is lung lost. Why do we spend time over this? Because indeed, if we acknowledge the fact that this fibrosis may or may not be there, then both this discussion, this debate, and the cascading part of management becomes very easy to understand. So today we'll talk of, is there enough scientific evidence and rationale beyond what Pankaj presented? And then we also talked of what Pankaj said, and I will completely agree that the hallmark of the pandemic has been the cycle of limited information, misinformation, ad hoc therapy, and we have got used to it, because inherently ad hoc therapy is something which comes closer to the clinician, and then he has to temper himself with, unfortunately, what science puts as both guidance, break, and the way of the future. So let's examine this issue carefully with 6 fundamental questions at this point. And these are the friends which have helped us through our medical careers: who, why, where, what, how, and when. And the first question we're going to ask ourselves is a so-called post-COVID lung fibrosis a true entity? Are we jumping the gun? And is the COVID damaged lung irreparable, which is the definition of fibrosis? So giving credence to that entity, let's see some cases. So you can see that this is a typical case of COVID pneumonia, and 2 months later, there's hardly any remnants left, and we know that this patient has improved both clinically and radiologically. Same thing here, this crazy paving, which is supposed to also go into complications, has minimal residual effects left out here. So again, a patient who has dramatically improved with a sick COVID pneumonia. And then this is as bad as it gets, a prototype of the most severe patients we faced. And when we saw this patient last year, we thought it's going to be trouble. And as pulmonologists trying to read stuff, we are seeing here bronchi getting dilated. And so is it traction bronchiectasis or is it a air bronchogram? All this was a lot of confusing information. And down the line, you see how this patient is dramatically getting better. And with both some judicious therapy and a lot of time and hand-holding, this patient ultimately will go to a really normal lung. So it is evident that the CT findings in most patients of acute COVID are largely reversible. And therefore, rather than use a term jumping from inflammation, which we saw, to directly residual fibrosis, maybe we should call it post-COVID lung changes, which is the way we actually represent a spectrum and not a jump. A spectrum means a patient has a chance to go through changes which may reverse. A jump to fibrosis means 2 points only, which is either good or not so good, and not so good is the trigger for therapy, especially as Pankaj pointed out, when we were losing patients left, right, and center. When you got them out, you don't want to go to them to go through second onslaughts. So rhetoric, fear, volumes, and concerns translated into ultimately calling this entity erroneously as fibrosis. And that is the problem which has triggered both a line of therapy and this particular debate. So we have made a case for the fact that misnomers create a cascade of this critical extrapolation and erroneous treatment. And that is why these entities came. If you have fibrosis, we want an antidote, and the antidote is antifibrotics. So we have given enough of a case to say this entity is a problem, and should we even think about it from that point of view, or reorient ourselves to a different mindset? So the second question is, okay, if there is this mild fibrosis also, there's going to be some residual fibrosis. Do these patients have long-term progression of disease, either functionally or radiologically, if you look beyond 3, 6, 9 months, and do their lung function or CT scan worsen over time? And why is this important? Understand, ladies and gentlemen, nothing in medicine can reverse fibrosis. All what we have in contemporary medicine is strategies to slow down fibrosis, and I'll come to that later. So, knowing the panorama of COVID-19 post-lung changes, as you can note the term, these changes worsen over time? Very, very important to define this. And this interesting study in Lancet Respiratory Medicine, a very important journal, as again some of these experimental therapeutic journals we keep quoting all the time, 3 months, 6 months, 9 months, and 12 months outcomes in COVID-19 related sick patients. And they were followed with all the parameters which matter to their pulmonary health, which is lung function test, CT scan, walk test, and subjective scales. And here you can see, you don't need to know too many statistics, but this is the DLC, or diffusion capacity, just got better over time. FVC, the cornerstone of trying to measure lung function bar plus minus fibrosis, just got better over time. And same thing, the 6-minute walk test as a functional parameter, as well as their subjective dyspnea scores by the MMRC, all got better over time. Only 5% of the initial 81% complained of dyspnea, that too mild. Their walk test was going from 535 meters to 615 meters, which was statistically significant. These patients, ladies and gentlemen, are just relentlessly getting better. I leave you with this thought. It's just that the speed varies, and if it is slow, we call it a problem, and we address the problem with another ad hoc entity called Anti-Fibrotics. And today we'll make a case that that should not be the strategy. What did the CT scan show in this paper in these patients? Well, 78% of patients had 3 months residual changes, and they were initially called as post-COVID fibrosis. But at 12 months, only 1 in 4 had persistent radiological changes. Note, it's changes and not fibrosis. And so that is why we are clearly seeing that in the majority of these patients, in a peer-reviewed high impact factor journal, these patients are consistently getting better. So where is the case for progression? There is only progression towards improvement and not progression towards deterioration, which is the trigger for so-called therapy. So this is a case we make again based on both clinical data and of course experience, that it is not progressive. Then, of course, comes down to opinions on opinions. And one of the ILD champions from the UK basically said, okay, initially, maybe this is fibrosis. Then they said catalog of uncertainties. And then they said over there very categorically in this radiology paper, another good journal, that CT scan findings, so considered to denote fibrosis, continue to regress in the long term. So understand that one of the pandemic's most interesting challenges has been what I thought in August 2020 is not true in currently October 2021. Change has been the middle name of the pandemic. And so we have to now understand that these changes are improving. They are not progressing. Repeatedly, we are trying to show papers, trying to show data, and trying to show opinions to justify that. A recent one, a paper earlier in the year in PLOS also looked at an AI-assisted HRCT and said that pulmonary fibrosis was improved or even resolved within 90 days. So these guys are saying, forget the 6, 9, 12 months. At 90 days only, you're seeing so much improvement. Another paper in a good journal to justify our logic. What about going in the past? Delve in the past to understand the present and comment on the future. That would be the paradigm. Natural history of ARDS, whether it was prior ARDS, it was MERS, it was SARS-CoV-1, or it was H1N1. Clearly, patients got better and better, and this was shown also in prior ARDS papers. And so we come down to the fact that assuming that my worthy opponent, Pankaj, is a brilliant person and very smart and erudite, as I said, even if he has to justify that there is fibrosis, comes down to one fact. Let's look at it for purposes of argument. Is this therapy even going to do anything at all? The antifibrotics, which took 30 years, ladies and gentlemen, it has taken 30 years to get one antifibrotic. Do they have any role, this entity? Can we take 30 years of science in a completely different area, and because of this common understanding of fibrosis, try to put it in a science which is there for 1 year in the pandemic of a lifetime where studies have been minimal to mediocre, and then try to use this particular 30-year drug? Is it something important we should think about? So question number 3 and 4 are, can antifibrotics reverse fibrosis, and what are they approved for? Well, plenty of papers. Pankaj showed perfenadone, the same papers of perfenadone, the NEGN papers, the Lancet papers, nintedanib, which was also talked about. None of them, please note these words, do not prevent or reverse fibrosis. They just slow down the progression of fibrosis. In the past few minutes, we have made a case there is no progression of fibrosis. So what are we going to use any drug for? And even if we theoretically in some wild fashion want to use them, when these drugs cannot even do anything about the fibrosis, why even thinking about these drugs? So the literature is clear. There's no ambiguity in those of us who have to double dip into pulmonary and critical care. Antifibrotics do not reverse fibrosis. And I made this statement earlier. In fact, nothing in medicine has shown to reverse fibrosis except for nature trying to salvage what is there. So what is the rationale in giving antifibrotics? At the most, one is trying to slow deterioration, but we said there is no deterioration. At the most, you have improving patients or static patients. And this trying to convert worse to bad, which was true for the IPF literature pre-COVID, has no footsteps or no footfalls at all in the COVID literature at all. So clinching the issue and trying to conclude very shortly, it's apples and oranges. We were desperate. I'm with Pankaj on that. I have also written some prescriptions that will exceed in the earlier years, but not in this year when looking at the whole course data, experience, and the perspective which has changed. So why use antifibrotics at all? What is the similarity to IPF or PFILD, which was the 30-year science it took to get these drugs in? Well, look at this comparison chart, natural history of IPF, PFILD on this side and COVID on the other side. I made a case, this is progressive, this is not. I made a case that this is an ongoing, on lung injury, this is not. Here we know it gets worse, here it doesn't, it is static to getting better. There is no worsening, the same point made over here. And honeycombing, which is talked of here as a hallmark distinctive feature, is rare, and this also remodels so well over time, as we will show you in some cases. So with this, I will show you a very drastic case, which actually looks like Pankaj is right, but then over time shows that that maybe not. See this gentleman we had to deal with, a separate situation completely, 4 months, 5 months in the hospital, horrible COVID barotrauma. There's scores of problems out here. You can see bilateral involvement over here. Anybody would try to say, make a case that this gentleman is heading towards fibrosis. There is irritation caused not only by the primary process, by secondary involvement, by therapies like chest tubes, and of course, the inevitable superinfection which comes in. So this lung, by and large, is not going to heal, or it's going to heal with fibrosis. We have dealt with a lot of issues with this gentleman, and I'll not go into that in the interest of time. Like we had to do a lot of things for the pneumothorax, we've placed blockers and all, which is done in our interventional pulmonary spectrum. But see now, 3 to 4 months down the line, I'm only talking 3 to 4 months. Already there is, as you will see shortly, and you don't have to be a chest physician or radiologist, there is improvement. Good lung is coming back, ladies and gentlemen. Minimal, sequelae are there. We will call these post-lung changes. We have no way of causing this currently categorical, condemning, progressive fibrosis. These lungs are already healing. This gentleman is extubated. He is decannulated and he's sitting home with an improving profile over 4 months after everything was done for him in a fashion which was unprecedented. So you can see how the X-rays also got better over time. Global consensus for the last question, is there any guideline? And obviously when we don't have data, if Ravi Mehta has to make so many cases and Pankaj himself is standing on shaky ground, not a single guideline has endorsed this. We only in India, it's so surprising that in India, we've used these drugs for a simple reason: cheap, easily available, and repurposed fast. Otherwise, every part of the world, when nintedanib costs $8,000 per month, you will not see antifibrotics used. And that is why I make a case very respectfully that my esteemed colleague is taking on the collective global wisdom to push a redundant, unscientific agenda. Take home message before we go in for the rebuttal: it is unscientific at this point to use antifibrotics because, again, to put things into perspective, the name itself is a misnomer. The changes are not progressive. They're improving to static, as we showed with both cases and data. looking into the past, neither of the prior ARDSs nor the similar coronavirus or similar viral pneumonias have been treated with antifibrotics. For that matter, we don't treat other post-infectious scarring, TB, etc. with antifibrotics, do we? We've never done that in our lives. And my respected proponent, please note that antifibrotics, even if some wild imagination you want to use them, will do nothing for this fibrosis by and large. The other entities, they have been extrapolated for strikingly different, and pathophysiology have very little in common to extrapolate with such audacity. And that is why no guideline is endorsing it. And as you pointed out, a lot was done, and we don't need to do it because of what we did before. It's always humility in science to say, okay, I did it because of X, Y, and Z reason, but not now. And now, of course, with science at this point showing no reason to do this, I don't think any patient at this point should be on any antifibrotic, with all the arguments we have made. Thank you very much for the attention. I think it was a very interesting thing, and I'm ready for any rebuttal with Pankaj. I think we have 3-4 minutes as per the organizers. Thank you very much again.
An excellent presentation, Dr. Mehta, as usual. And I'm hoping both of you would choose your rebuttals as feisty or as social as it can be, and then probably we could discuss maybe a little bit more about the inflammatory lung pathologies that actually evolve from the chronic lung disease, just like how we've seen with H1N1. So Dr. Pankaj, you have something to say? Yeah, few slides. Yeah, go ahead.
Yeah, no, I don't have slides. I'll just.
Yeah, sure. You go ahead. Yeah, please. Yeah.
So first of all, sir, an excellent presentation. Let me congratulate you. You are a thorough gentleman, as is obvious here. In your magnanimity, you have actually used a few cases just to prove the point. Now, the whole issue is I beg to differ that no case has progressed or no worsening happens in patients with severe COVID pneumonia. At the moment, I don't have the CT scans. In fact, I have 3 or 4 of my patients who are actually worsening, and we've ruled out any other cause of it. So I beg to differ on that, sir. This is a very rosy picture that has been presented. While we agree, both of us agree that we don't have much of the data available, fibrotic lung disease is a situation in any situation, whatever be the etiology, it is one of the most difficult diseases to handle. There is no cure, of course, for any form of fibrosis, but it definitely slows down, as you rightly pointed out. And as I accept that this is too early in the life cycle of the pandemic for us to give you data, but if you find these therapies useful enough to slow the process of fibrosis, I think the same logic goes with the worsening fibrosis, I would use the word still, in patients who have had bad COVID pneumonia. So I think I rest my case with that. This is something, these are early days yet. The final judgment would be coming later, but you can't completely rule out this form of therapy. I think you would agree on that. We need more time, more research, more study to finally come to a conclusion. I rest my case.
You want to add anything?
Yes.
So I think I have a few more slides. And if I'm the one supposed to speak, please let me know. Yeah.
Go ahead. Yes.
Yeah. So Pankaj brings about, to give full credence to a clinician and somebody who has gone to the literature. There is never and never and never and always in medicine. So there will always be some outlier. The question that comes down to, do we take the entire lot of people who have been put on this erroneous label and subject them to these therapies indefinitely with little science, little understanding of where to head with them? And then the biggest thing of COVID-19 is if they're getting better anyway, which we showed at length, not only by cases, but by stark literature. The Lancet Respiratory Medicine is proof by itself. then you'll be giving credence to the drug, and the drug is doing nothing. The drug is actually doing nothing, and you are thinking that your drug is improving things, and that not only is bad for the cause, the science, it also puts a memory in your mind, and as a leader, one will go and project that, find that this is what happened in my experience, and there's 10 others waiting to follow you. So let's not forget that there's a non-scientific human cascade which took center stage in COVID also for the therapies we used. Let me back this with some evidence also. Nothing speaks better than our own cases. So to answer the question which Pankaj and I debated, we said, let's get histopathology. And we managed to get an IRB approval, and we've gone and done histopathology on some of our cases. And we'll show you some stark data to show what, to substantiate from Indian patients, our own patients, which we are trying to also put out there. 22nd day, and the same thing, I'm not going to go through that. These patients go through the horrors. 22nd day, look at the histopathology out here. What do we have here? We have remnant hyaline membranes. We have organizing exudates. We have some sort of alveolar damage out here, but we have no fibrosis out here. That's why we called it vascular zero, fibrosis zero. This is 22 days. A lot of the times people give up saying third week fibrosis is starting, they're stiff, we can't ventilate, this guy is not going to make it. 39th day, this 45-year-old gentleman who has this sample over there, you can see there is viral inclusions we're catching at that time. Please note, this is a 39-day. Viral inclusions, hyperplasia of type 2 pneumocytes, but no categorical fibrosis or honeycombing. So we're talking the 5th to 6th week of disease over here. To see it in high power also, again, hyaline membrane, typical of ARDS, more and more over here. Microthrombi attesting to the vasculopathy of the disease. Inflammatory exudate, which some people will say should improve with at least some low-dose steroids given. Some case can be made. But currently, no categorical fibrosis in this particular case either. Look at this third gentleman, an 82-year-old whose families went on endlessly at 53rd day. What do we see out here? Pneumocyte hyperplasia and a fibrinous exudate. So Pankaj, with you on the fact that it is starting to lay down out here. It's a fibrinous exudate. Fibroblastic proliferation, but fibroblastic proliferation and fibrinous exudate is not end-stage fibrosis. It is not a harbinger of progressive worsening. So we showed in our own cases over here that by and large, what we thought was fibrosis is actually not end-stage fibrosis of progressive damage. Note the choice of words we are making, and note that that may influence your decision not to use these patients indiscriminately. So to conclude, to leave a clear message, COVID-19 ARDS resolves well in most cases. Pankaj, I accede that some always will be there who will break the rule, but I also insist that that doesn't make a case for treating so many people as is happening now. In the few who have fibrosis, it is not progressive. So think long and hard until you cause it a progressive phenotype. So it behooves you, if you actually put your prescription on this particular agent, to make sure that it is progressive, not only in your impression, but also by objective parameters. Extrapolating from the well-known entities of IPF and progressive fibrosing ILD is not correct for the patients, as has been done in the last year or so. We also say that antifibrotics, for all the above reasons, are not useful until you demonstrate unequivocal progressive fibrosing ILD. And don't forget, some of those cases where we see may actually have an ILD which is interacting with the COVID phenomena, and it may not be a primary COVID disease which is progressing. Please keep that little thought in the back of your head. We know these drugs don't reverse progression. We just retard it in the right phenotype, not in the COVID phenotype. And hence, when you have fixed damage of COVID, you don't need to use an agent just because you have it indefinitely for months together. Understand that nintedanib was also expensive till a while. If you had the COVID pandemic before it came off patent, it was costing at this even 50,000 per month in India. So I propose that patience is the key, not medications for most patients. Nature and time are better choices at this time. I'll leave you with this Voltaire comment. The art of medicine consists in amusing the patient while nature cures the disease, which I propose, prove, and insist is the situation with most patients so-called labeled as post-COVID fibrosis. Thank you very much.
So thank you, Dr. Mehta and Dr. Pankaj for the excellent presentation. And, there is nothing, in this PROCON debate, there is nothing like winning and losing. It is just like, we are assigning the case to the eminent lawyers, just like, every lawyer can only, argue based on the merit of the case. You cannot, whatever the case they have. So in this, debate, obviously the con was with Dr. Mehta and the pro was Dr. Pankaj. And I believe that both of them are argued well. So my thing is, I have a kind of a conflict of interest in commenting about anything, because, I should admit that, in our practice, we are not using, obviously any the so-called anti-fibrotic agent. But, as you said, Dr. Mehta mentioned at some stage, maybe a year ago, Dr. Mehta himself was using some fibrotic agents, anti-fibrotic agent. So what I understand is that at least the post-mortem studies, more than 50% of the people, Dr. Pankaj has shown in the slide, more than 50% of the patients had fibrotic changes. Obviously, you never know what happened, because these are the patients who are already dead. So we never know how that would have progressed or not. That is one thing. And after the survivors of, the COVID thing, the so-called, whatever we call, we have to be very cautious about talking fibrosis, the post-COVID changes. They can be in 3 categories, and which can be healing. Vast majority of them will be healing. They are improving, they can regenerate, they can improve. And some personal cases can be, static. And the third one, Dr. Pankaj has shown, one third of them, and a few of them can be progressive, which, probably the progressive doesn't appear to be there. That's, there is no progressive, the fibrosis, the progressive damage which is not happening to the lung. That's what, Dr. Mehta was trying to say. And here the key point is that, the available fibrotic, as far as nintedanib or, your pirfenidone, they are known to non-reverse or prevent fibrosis. If at all, they can slow down the progress of the lung function, the worsening of the lung function. That's what I understand. So probably SDAC inhibitors, whatever Dr. Pankaj has mentioned, I'm not very sure how they can have an effect on the fibrotic, the fibrous aspect of the lung. So so the thing is that at the moment, I also believe that personally, my point of view will be that probably there is no role of a, anti-fibrotic medication. There is nothing to, as Dr. Mehta has mentioned, there is nothing to prevent or, reverse any fibrosis. You can just slow down. But again, Dr. Mehta, I have one question to you. You are telling that there is no fibrosis happening in the lung. So what I mean is that, that means that there is no irreversible damage happening to the lung. So the question will be that then why should the patient go for lung transplant? And it's a very debatable thing. I just, so if there is no fibrosis, I mean to say, forget about progressive fibrosis, the fibrosis has happened. That means there's a irreversible damage has happened to the patient. So I believe that these are the patients who need to be considered for, and you believe that if the patient is not going to improve, some irreversible damage has happened. These are the patients who are to be considered for lung transplant. So don't you think that there is some irreversible damage is happening in those kind of patients who is going for lung transplant? I know it is highly debatable, I know, but just, No,
so I think what's happening is, Ajit, because we make such emphatic cases, both Pankaj and me, we tend to give black and white impressions. There's no black and white. It's shades of gray over here. Even the Lancet paper showed that ultimately 24% of people have residual changes. No one is saying that there is no permanent damage. We're trying to say this is not progressive fibrosis to merit antifibrotics. There's two different things.
I agree. Absolutely. I agree with that. At the same time, I'm asking that there is a subset of patient who is having irreversibly damaged lung as well. No. I agree with the anti-fibrotic thing, which is very debatable. And obviously, whatever the available thing, we have already discussed. We are sure about that. But there are patients who had irreversible damage to the lung. I know that, one of the most important challenge even for decision about lung transplantation itself is to say that, say that the lung is irreversibly damaged. It is very difficult to prove or disapprove, because there are people, the current guidelines say that after 6 weeks you consider for lung transplant. But the problem is that it is almost impossible. It's extremely challenging to say that one patient who is in front of you, his lung is on ECMO, whatever, his lung is irreversibly gone. Because the problem is that even if you go for a lung transplant, around the 5-year survival may be around maybe 60%. So it is better to have our own lung healed rather than going for a transplanted lung, So basically the thing is that, but a subset of patients still believe that there is irreversible damage that's happened to them. And, obviously there is no treatment for that at this point of time.
So to add to your point, Ajit, the whole question is what is actually happening to these patients to merit consideration for transplant. There's many things, right? You have barotrauma, you have vasculopathy, you have fibrosis over there to whatever extent, there is pleural components out there. There is so many other things. So the consideration for transplant is based on a total a lung failure situation. We are equating lung failure to lung fibrosis, not the case. So few patients will go to transplant ultimately, and that has been done also. The second is trigger for transplant. The trigger for transplant is not supposed to be as soon as it was done before. Even Toronto changed its strategy because of the data and realized that you can continue ECMO up to 120 days. The threshold used to be 4 weeks. It's gone up to 120 days in people who can run it and who have the bandwidth, and societies who can do this, because a lot of people will heal. If I'm going to come down to 2 liters or I'm going to get better, it's not necessary you put me on the transplant list. So that also changed over time. So fewer and fewer transplants will happen over this. And lastly, the biggest question you're asking is, will antifibrotic prevent the transplant?
No, that will not. That's absolutely. I agree with that. Yeah. So thank you, Dr. Mehta, Dr. Pankaj, for the excellent presentation. We have a little bit of shortage of time. I think we should move on to the next topic. Dr. Justin, can you introduce the speakers? Any questions are there? I can put it in the chat box. If time is, we'll be discussing.
I think Dr. Murali Mohan had posted an excellent question, and I hope the speakers would take a couple of minutes to type out their response to it. And I think it is a genuinely good question. Even though I still disagree with starting antifibrotic therapies for that question, but it is still worth that a couple of minutes of time. I request Dr. Ravi Mehta and Dr. Pankaj to engage with that question. Thank you, Dr. Murali Mohan, for that excellent question. Coming to the next topic, we have our own Bangalore team pitching one against each other. I wouldn't want to go ahead and say that this is it's one institution against another, but but anyway, I would introduce Dr. Indra Menon from Baptist Hospital, a senior intensivist and examiner and a thorough lady. She's going to debate the topic of NIV in ARDS with Dr. Bhuno Krishna, an intensivist physician from St. John's Hospital, Bangalore. And they both are senior clinicians and examiners and eminent speakers. And I hope to have an excellent debate this evening. And I hope that would alter the general practice of NIV use in ARDS whilst we prepare for third wave of COVID cases. Thank you. Welcome, Dr. Bhuno.
Can you see my slides?
Yes.
Yes.
A very good evening. We've just had a very interesting debate, and now we are going to debate on the topic NIV in ARDS. I'm going to speak for the topic. So how would you want your patients to look like in the ICU? Would you want them to look like this? Or do you want them to look like this? So basically, when you say NIV in ARDS, if you say no, that means you're going to say yes for intubation. So actually, this debate is about, is it between NIV or are you going to intubate the patient? So this is basically the crux of this debate. So why do we prefer NIV over intubation? As we all know, intubation has several risks. It causes airway trauma. Patient can have a cardiovascular collapse. It can cause infections, ventilator-associated pneumonia. There's prolonged ICU stay, and so on and so forth. And we know NIV has several advantages. It improves oxygenation. It decreases the work of breathing, avoids the complications due to intubation, and definitely a shorter ICU stay. Over the years, if you see, this study is showing the NIV use in all cases. Over the years, this is still 2015 only, you can see there's been a progressive increase in the use of non-invasive ventilation, and there has been a progressive decline in the use of invasive mechanical ventilation. So NIV has a very strong evidence of benefit in patients with COPD exacerbation, cardiogenic pulmonary edema, in immunocompromised patients with acute respiratory failure, or do not intubate patients with acute respiratory failure. The evidence is so strong in these cases, but why is the evidence so poor in NIV use in ARDS patients? Because the papers or the literature has been very scarce, but then we are going to soon go through the forthcoming slides and the evidence, and we are probably going to change and make it for the use of NIV in ARDS. None of us are, are going to escape the powerful Vajra Ayudha. And I'm also not going to probably escape what the Vajra Ayudha is going to attack me with. Nor am I powerful like Karna with the all-powerful armor. But definitely, I'm going to build an armor of scientific evidence against the Vajra Ayudha. So I'm going to go through the evidence for NIV in acute respiratory distress syndrome. So I'm going to divide the evidence for pre-COVID era, and definitely the NIV use has increased in the COVID era. So I'm going to divide the evidence in these two categories. So we have had a very interesting study that was published by Antonelli et al. It was a multi-center survey study on the use of NIV as a first-line intervention for ARDS. What was found that in expert centers, NIV use as a first-line intervention avoided intubation in 54% of treated patients. Another very interesting study published by Patel et al. In 2016 had compared the use of helmet versus face mask, and it was seen that helmet use reduced intubation rates and 90-day mortality that was very significant. Then is it an interface issue then? Our helmet interface is better than face masks. That is why we had not had great evidence of NIV use in ARDS. Another very big study that was published in 2017 by Bellani, it's the Lung Safe study, which was done on more than 3,000 patients with ARDS, and the use of NIV was about 15.5% on day 1 and day 2 of ARDS, all types of ARDS, that is mild, moderate, and severe. What was found that 78% success was noted with NIV use in mild ARDS and 55% success rate in both moderate and severe ARDS. So that's good news. So that means in 78% of the cases, you could avoid intubation if you use NIV in ARDS patients. So I'm going to be honest. I'm not going to hide facts or confabulate. I'm going to plainly put what are the drawbacks of use of NIV in ARDS. I'm sure my worthy opponent is going to put it forth anyway in the slides. So let me state the drawbacks of NIV in ARDS. Yes, it's going to be difficult to give high PEEP. There are going to be leaks. There's going to be discomfort for the patient. Patients may not tolerate even mild disconnections in the mask or when the patient is on NIV because they are hypoxic. Lower PF ratios, patients may be sicker. They may have multi-organ failure, so they may not tolerate NIV, and you may want to consider intubation right away. And it is noted in all the studies that delay in intubation is an independent predictor of mortality. And high tidal volumes cannot be regulated in a spontaneously breathing patients, which can cause patient self-inflicted lung injury. So, but during the COVID era, what was noticed that there was a dramatic increase in the use of NIV in ARDS patients, from 15% from the Lung Safe study to almost 30% increase in use of NIV. Although guidelines stated, especially the WHO had stated, NIV should be avoided in a pandemic because of the high risk of transmission of the virus to the healthcare workers, there was still a significant increase in use of NIV. And from India, we are never going to get the true figures of how was the use of NIV, what was the experience of use of NIV, and what was the success of use of NIV in these patients. So why was this sudden increased use of NIV during this pandemic? We've had several reasons. I'm sure you're all going to agree with me. The common cause for death in this COVID patients was severe hypoxia. So NIV was very beneficial in these cases. ICU beds with ventilator was scarce even in the big cities. So NIV, that is the BiPAP machines, could be used even in ward settings to help alleviate the respiratory distress in these patients. High flow nasal cannula machines can be used, but they are expensive as compared to portable BiPAP machines. So in all centers, HFNC could not be afforded in large numbers. The irony was NIV usage is considered to be labor intensive, but during this pandemic, it was considered less labor intensive because if a patient is hypoxic, the nurse can just strap the patient onto the BiPAP machine and reduce the respiratory distress. So that was the irony during this pandemic. Less skill was needed because we saw that several healthcare professionals with less skill for intubation were taking care of sick COVID patients. So it was easier to put the patients on the NIV rather than go on to a risky intubation, causing more risk to the patient. Lungs were more compliant, needing lesser PEEP, so these patients could tolerate the NIV. So did NIV reduce intubation and mortality in COVID ARDS patients? If I were to ask this question to the audience, I'm going to say yes or no. I'm sure I'm going to get an answer of yes. And do we have evidence? Don't go by just asking a question of yes or no. Was there evidence for reduction of mortality in COVID ARDS patients? Yes, there was an initial study that was published in 2020 from Wuhan, where they said that those patients who were intubated, the mortality was 92%. So this had dissuaded many centers for going on to, hastily intubating the patients who had respiratory failure. So why did the NIV fare better than invasive ventilation for COVID ARDS patients? Were there reasons? Yes, as I had already mentioned, manpower issues for intubation. For proning, once you intubate the patient, you would need manpower for proning. You would need monitoring issues. Whereas if you have the patient on NIV, you would see the patients are so cooperative, they could prone on their own. They needed less nursing care. They could feed, the family members could be by the patient and they could help in taking care of the patient. And there was lack of infrastructure, that is the ventilator, as I'd already mentioned. And once you intubate the patient, you need infusion pumps for sedation, paralytics. So all these were a big issue. That is why the NIV did better than invasive ventilation for COVID ARDS. And of course, once you've intubated, the infection control practices had hit the roof, and it was difficult to adhere, especially with the load of patients. The clinical course of the disease was also different in COVID ARDS patients. Some responded to therapy so rapidly that NIV was sufficient and avoided intubation. So was the NIV useful only during the COVID pandemic? No. There have been previous studies that were published during the SARS epidemic also, which was published in 2004. And it was found that NIV was effective in the treatment of acute respiratory failure and avoided intubation in 70% of the cases, with shorter ICU stay and fewer complications and less risk of exposure to the healthcare workers too. So we all love guidelines. We don't like just, here and there RCTs, and we would want guidelines. But the sad thing is we have only the 2017 guidelines by the European Respiratory Society and the American Thoracic Society, where they recommend the use of NIV only in early ARDS. They should be managed by an experienced clinical team who can set the NIV settings appropriately. You have to carefully select the patients. Definitely, there should be no contraindications. You need to closely monitor the patients, reassess early, and intubate promptly without delay. So the crux here is mild to moderate or even severe ARDS. You could give a trial of NIV. You would monitor for about 1 to 2 hours of NIV and see if there's any improvement in the PF ratios. And is the interface going to make a difference is something that we need to consider. This is an interesting article that has been published by Tobin. Tobin is the author of the mechanical ventilation textbook, where he mentions that non-invasive strategies in COVID, epistemology, RCTs, guidelines, and physiology, where he mentions that some RCTs, the results from RCTs, based on these RCTs, guidelines are wrongly stated without taking the true picture or the clinical experience of the patient. So he states where two studies have shown the dramatic effect or benefit of CPAP in COVID-19 patients, highlighting the problem of a landmark trial based on which a guideline is framed. Thank you.
Yeah, thank you, Dr. Bhuvana. Dr. Indira Menon, madam.
Hello, good evening, everyone. Nice to be with you all. And thank you, Ajit and Justin, for this opportunity. Hi, Bhuvna. Nice to see you. Now to come to my topic, I'm speaking against NIV in ARDS. And it is a difficult topic, I know, because, but NIV has been time tested in a lot of respiratory problems, and it increases the minute ventilation and reduces the workload of the patient, muscle load. But the ones that Bhuvna mentioned is what I also say: hypercapnic respiratory failure and acute cardiogenic pulmonary edema. These definitely, because these are acute reversible conditions. There's no problem in using NIV there. But ARDS is a different ball game. This is a complex, it is a complex situation where the ventilatory mechanics are different. Gas exchange is a problem. And these patients are much sicker. They have multiple problems like a stiff lung, severe hypoxemia, sepsis, multi-organ dysfunction. So here we are dealing with a hemodynamic instability, which is far more than the average COPD or acute LVF. There have been, as Bhuvna said, very few studies, proper studies on ARDS and NIV. There have been high failure rates. I'll come back to some of the studies Bhuvna mentioned. And more frightening or worrying is that the failed NIV patients had a higher mortality. So maybe one has to look at that. The next, we all know about the ARDS mantra, the ARDSNet protocol, PROSEVA, Accurasis, and all of us follow lung protective ventilation, proning, neuromuscular blockade in difficult patients, sedation, and nutrition. Now, how does NIV affect all these? I always thought, frankly, that tidal volumes would be lung protective in NIV, but actually we're wrong there. The ventilator be set as low tidal volume, but the patient is a tachypnic dyspneic patient, and the patient effort generates a higher tidal volume than what is set, and that sometimes we don't measure. The lungs are stiffer in ARDS, so there's a tidal hyperinflation. So barotrauma, lung injury is quite common in non-invasive ventilation. So it is not a simple, innocuous procedure when we put a patient on NIV. PEEP, yes. Air leak, Bhuvna told, I would say that definitely air leak is a problem. And the more pressure you put to increase the PEEP to improve the oxygenation, the patient becomes uncomfortable. And especially in the acute phase of dyspnea, it is like a person gasping for breath in a swimming pool. So they will not be able to listen to reason. So it'll be very difficult to increase PEEP in these patients. And this auto-triggering can cause, a lot of auto-PEEP development, and that is another problem. Proning, difficult, but in that helmet mask that Bhuvna showed, and I have a slide here also, people have done it. We all do proning with NIV patients, but it is not a comfortable procedure to prone, and you need a very cooperative patient to prone. And this is a cooperative patient who we cannot sedate much. And most of the studies have shown very limited proning. The PROSEVA trials at 16 hours of proning, we do 12, 14, whatever is most comfortable for the staff and the patient. And but most of the studies of NIV in proning have done 2 hours morning, 2 hours evening. So it's not a prolonged proning that is what is recommended in the PROSEVA trial. Sedation, of course, you have to be careful. You cannot do sedation out of the ICU setting. And yes, remifentanil is there. You have dexmedetomidine, but they may not be enough in these acutely dyspneic patients of ARDS. Neuromuscular blockade, absolutely not possible. Then the problem is of nutrition, what to eat, should we feed them? There's a French trial that said that you don't feed the patient. 60% of the patients on NIV are not fed for 2 days. And that itself is a cause of mortality. In fact, some of the NIV trials do not advise enteral feeding because they say if you feed enterally, the patient has a higher mortality. Now, why don't we feed enterally? Why are they scared to feed enterally? Because there's always that sword hanging on our heads that we have to intubate the patient. So we really don't want rice and sambar inside the patient, and then it'll be a real problem. The other thing is the nasogastric tube itself is a source of leak. Then if we feed the patient, gastric distension, aspiration. So all these problems are real in the world of NIV. And when we disconnect the mask and feed them, we lose PEEP. So all this becomes unstable. And we know that the benefit of PEEP is to keep it persistently there. You cannot have the sheer stress of losing PEEP, reinflating the lung. Yes, ventilator-associated pneumonia is a problem with intubated patients, but patients on being fed, having aspiration risk, limited oral care because you have to remove the airway and clean the mouth. So I don't think VAP is as less as we assume it to be. So ventilator-associated pneumonias can be fairly common with non-invasive ventilation. The other thing is the interface. Yes, the helmet mask is the latest study by Patel et al. In JAMA, where they said that the helmet mask did better than the face mask. But the helmet mask also, the dead space is far more because the volume of air there is more, and there's a lot of carbon dioxide rebreathing. So we need many more RCTs before we can say that the helmet is as good as the study by Patel et al. Said. So all these factors, we realize that patient-induced ventilation injury to the lung is fairly common in NIV because the patient is an acutely dyspneic spontaneous breathing patient. And there are some studies which say we should not have spontaneous breathing in patients with acute lung injury, but that's another debate. And ventilator-induced lung injury, barotrauma, is not at all uncommon in patients with NIV. So we're back to square one. Is it harmful or harmless? Everything with a pinch of salt, definitely. NIV can be less harmful, let me put it, if you select the patient correctly. I still believe that the mild ARDS patients definitely try NIV, but moderate, you have to be careful, and severe, there's no question of trying NIV because you are losing a lot of time, the preparatory time to intubate, and somehow the patient getting a good SpO2 on NIV lulls the staff into a sense of security, lulls the nurses into a sense of security, and everybody feels that the patient is okay. So close monitoring is very important. Yes, in COVID, during the COVID pandemic, all of us went and we ventilated patients outside of the ICU. But COVID was different, pandemic rules were different. I would not advise NIV anywhere for ARDS patients except in the ICU, where we have to be ready to intervene at the drop of a hat. So it's a very tense situation for the staff also. You need a very good nurse to monitor any deterioration in the patient. The doctors on duty should be very, very competent on intubating a hypoxemic patient with very little oxygen reserve. So we have lost time where the doctor can respond or the staff can respond by putting a severe ARDS patient on NIV. So it would be a little risky. Interface is important. If we can get masks, definitely we should try it and see whether that works, because yes, intubation is a problem. But a lot of patients face claustrophobia with these masks, and that can be an issue. Proning such patients also a problem with these masks. And a lot of them look like they came out of a boxing ring, and maybe the plastic surgeon will have to do some nose repair after we've finished with the NIV there. So I would like to talk about some of the studies, one of which Bhumna mentioned, Antonelli, Yes, there was 54% reduction, avoidance of intubation. But when you look at the study in more detail, like somebody has analyzed it, they found that the denominator was much lower than what it should be, because they didn't include patients that were intubated outside the ICU. So finally, all told, there was 15% reduction in avoidance of in the number of patients intubated. There was higher VAP in these patients, and mortality was higher in patients failing NIV. Zahn et al. Also, there's an which said that NIV is better, but these patients, when you look at the details, the PF ratio was 200 to 300, so they were mild ARDS patients and not the severe ARDS. Frat et al. In the Florali study added one more googly into the whole thing, a new player, HFNO, which lowered the intubation rate more than the mask ventilation or NIV. So HFNO is a strong contender to prevent intubation. The lung safe study that Bhuvna mentioned is a very good study which looked at the epidemiology of ARDS. But when you look into it, the mortality was much higher in patients with the degree of severity of ARDS. The mild ARDS was 22%, whereas the severe ARDS was 47.1% mortality. As NIV was only used in 15%, but as a patient with a PF ratio of 150 had a higher mortality than a lower PF ratio, than a higher PF ratio, sorry. So severe ARDS had a higher mortality in the lung safe study. So where are we now? I think I've put my case for not using NIV or using NIV very judiciously, but we fall back on experts. Dr. Gattinoni, who's a guru of ventilation, he says that this was for COVID. If patients show clinical signs of excessive inspiratory effort, intubation should be prioritized to avoid excessive intrathoracic negative pressures and self-inflicted lung injury. Then the European Respiratory Society does not recommend NIV in de novo acute respiratory failure. And our own guidelines say do not recommend in PF ratio less than 150, not to try NIV. You can try it in early ARDS. If you're using sedation in NIV, which a lot of acutely dyspneic patients will need, it should be in an ICU setting. So personally, definitely use it with caution. You have to have a very experienced resident on the ground who will be ready and competent enough to intubate the patient. There should be, in case of deterioration, and that the staff should be able to be told that this is a patient who will deteriorate anytime and not to be complacent about it. On a lighter note, if you intubate the patient sleeps well and you sleep well. You sleep better, okay, not well. Thank you so much.
Menon. Dr. Bhuvana, you want any rebuttal? You want to add anything?
Yes, I'll just one slide. If
Yeah.
So as Dr. Indra had mentioned, that it is not a strict no for NIV and ARDS. Yes, you could use NIV and ARDS cautiously in the subgroup of patients with the PF ratios of less than 150 with close monitoring and with the experienced staff, and do not delay intubation. That's what I had also mentioned in the slide. So I have defended NIV well, and at this point of time, I'm game for an audience poll. I'm sure I'll have more votes for NIV in ARDS. Thank you.
Yeah. So thanks. Yeah. Madam, you want to say anything? Dr. Indira Menon?
Yeah, definitely. Yes, Bhuvana is very confident. I'm happy about that. But she did mention about NIV in COVID, that they did very well. Actually, my experience is a little different. COVID NIV worked because there was a lot of happy hypoxia. And that was actually dangerous for me, at least. I felt it was a worry, because intubating a COVID patient suddenly put the staff at risk and things became a little more messy. So even in COVID, I felt it was better to intubate a little early. Yes, infection, especially in the second wave, was a big problem. And I was also hoping that the patient would be not intubated. But this happy hypoxia was actually really killing us, because patient was happy, we thought everything is fine, and then suddenly they'll deteriorate. So that was a bit of a worry. And at that point, to put everybody at risk was a worry.
So Dr. Bhuvana, so when you have an option, you have an NIV, you have an HFNC, and you have a ventilator in an ARDS patient, which will be your option? You say, for example, let's say it's a mild, so-called mild ARDS. You have an HFNC with you, you have an NIV with you, and you have a ventilator with you. So what would have been your option? No, you're pro for NIV, but I'm just asking, you have an HFNC also with you.
So if the patient has increased work of breathing, I would definitely consider NIV rather than HFNC. If the patient doesn't have increased work of breathing, then HFNC is a good option, because even with the higher flow rates, patients are more comfortable with HFNC if it is available in your setup, because not all setups can have that many HFNCs, especially during the first pandemic. I don't think any of the ICUs were equipped with that many HFNCs. So HFNC is a good option if there's no increased work of breathing. Otherwise, I would prefer to use NIV.
So Dr. Justin? Dr. Justin?
Yeah, good evening, madam.
Yeah.
I think
Justin is very much interested in the topic. We used to have a lot of arguments in our ICU with Justin. So I wanted Justin to discuss something. Yeah,
Justin took a much extreme position of not putting a single hypoxic patient on an NIV.
No, that's how you just discussed this.
But obviously, we were discussing in a scenario of varied healthcare settings, not necessarily an ideal tertiary care center, versus a pandemic situation and availability of resources. And I think that probably has changed the way how we utilize our I think point of talk became resources from an NIV point of view, equipment, people, and when it sorry, I think there was a bit of a disconnection. So anyway, I think that was probably it turned out to be, rather than an NIV and ARDS, it turned out to be either NIV or mechanical ventilation as a process in this pandemic, with all its other things attached to it, like resources and manpower. So I think that's probably what I took away from this talk, is that unlike how we on a non-pandemic times, in which case I probably would have favored Dr. Indraman's point of view, but I think I can only make a comment that the rationale for using NIV in type 1 respiratory failure is more to do with everything else around the pandemic, rather than specifically to do with the NIV. And if anything to go by, I think the strategies where NIV is used, particularly most of our centers are not specialized NIV units, even in tertiary centers. Number two is that most of the time we give them for far too long than necessary. And that's probably the two main reasons why I side with Dr. Indramanan. And I'm happy for others to make a comment.
So yeah, so thanks, Dr. Justin. So the thing is, at least, I will say that based on our practice, maybe till 5 years ago, so what has been, maybe approximately, what has been conventionally taught to us that in mild to moderate ARDS, when patients who are hemodynamically stable, you can always give a trial of NIV. And, this is probably there is a lot of subjectivity in this, I know. And there is a low threshold to intubate. See, the issue is that with the low threshold intubate, again, is a very, very tricky situation. Like, there is a lot of subjectivity there. So I would like to say that now, when two people, one of the persons is having a doubt that whether we should intubate or not, two equally, competent intensivists or registrars or whatever, one of them is having a doubt whether I should intubate or not. That kind of a doubt is coming. You have a low threshold. In one person has got a doubt whether to intubate means you need to intubate. But this is only applicable for the mild to moderate ARDS patients who are, who are hemodynamically stable, I would like to say. But having said that, there are some kind of a recent concerns. I think Justin, we have discussed a lot in our unit as well, like about the patient in PSLI, whatever patient in a self-inflicted lung injury, or what you call effort-induced lung injury, EILI or SILI, and basically this the effort-induced lung injury that is coming from certain concerns that for example, one is that the cis attracurus trial, because one of the the intervention which has been known to reduce the mortality is the neuromuscular blocking agents. And obviously the mortality, one of the reason why the mortality is supposed to be less in the patients who are the paralyzed was in a patient who received the neuromuscular blocking agents were there, that those patients the patients are not unlikely to breathe, and also naturally there is no kind of patient on ventilator breathing, no kind of increased tidal volume happening. So there is a ventilator-induced lung injury is prevented. That is one thing. Second thing was, as Dr. Bhuvanekrish and Dr. Indra, both of them have mentioned about the lung safe trial, where some kind of ad hoc analysis. Obviously, the ad hoc analysis itself is having a lot of things to debate on that. But still, the patient in that ad hoc analysis, they found that the patient who's having a severe ARDS, the mortality was more when the NIV was used. So, so that is more in favor of, not in favor of NIV, because the NIV was used in severe ARDS, the mortality was more. The third one was, there is one single-center randomized control study was there about APRV. One of the trials has shown that there is increased mortality, the patients who are allowed to, the APRV was put where you allow the patient to breathe their own. So these are some of the things which made people to think that, the effort-induced lung injury could be an issue, or whatever the patient PSILI, patient self-inflicted lung injury could be an issue, and which can increase the mortality in ARDS if you put the patient on NIV. But as you said, because the only thing is that the effort-induced lung injury or the self-induced lung injury, is there all just a theoretical experimental discussions, or is it really translated into clinical outcome? I think it is yet to be very debateful. That's what I presume at this point of time. Dr. Justin, you think you if you have an HFNC with you, you will try with HFNC before you put the patient on a ventilator?
Like I said, I think it is to do with the resources, and if I have all the resources available, then I probably never use NIV in my ICU.
So you will not even try on HFNC also before you put the patient on a ventilator?
Not. I will try HFNC and go. High flow. Yeah.
So will you try that instead of?
Yes.
So you believe that high flow is unlikely to give this kind of a higher tidal volume? Am I right? That's what you think? This kind of a higher tidal volume, the self-inflicted lung injuries.
So I think, in my understanding, Willi and Silly. So the Silly that is still possible with the high flow, whereas Silly and Willi that happens with the NIV is proportionally more damaging to the patient, particularly if it is given beyond certain period, because we no longer use all these ROX indexes or any other scoring system for NIV failure. We never do the once we've stuck it on, we just leave it. We see it for a few minutes. If they look okay, or if the numbers get better, we leave them. We don't never realize that the changes in mechanics or changes in oxygenation, we never follow up. So, and I mean, I guess that's the reality, ground reality, even in a tertiary center. So I would probably make a case for the delta change in the way how much support patient is needing, and escalate to ventilation. And that's probably where the money is, where you would reduce the risk of both Silly and Willi, as you quoted so many studies, Ajit. Yeah.
So even based on the current evidence, can we say that conclude that, just for a consensus, can we conclude that mild to moderate ARDS patient, who are hemodynamically stable, you can give it with a trial of NIV with a low threshold intubate, just for because obviously we are quite aware of the ILI and the what do you call that, the Silly, but still at this point of, because we have to look at the resource settings as well. And every patient you cannot intubate, that's one thing, and every patient, for intubation also, it is having its own issues as well. So at least at this point out in the severe ARDS can never be put on an NIV. You could even never put on an NIV or a non-invasive technique. Am I right? That's what is Dr. Justin you would like to say?
And I think as Dr. Buna just messaged, I think NIV trial, particularly in the initial stages. So a hypoxic patient needs a positive pressure, never in hours. It's always more than a day and a half. So the trial is only going to discriminate whether you're going to continue to give the NIV for this patient or escalate to intubation ventilation. There is not going to be a patient who's hypoxic enough to have a PF ratio, which is 200 to 300, for a discussion's sake, would never get off that machine for the day. So you are putting the patient at risk of positive pressure for a day or a longer. And that is where the crux of it is and that's the reason why if the resources are not there, it's a different situation. As an intensivist, we all know how to triage the resources, and whatever that is handy, the best available is water. If it is the best available for me options, I would do high flow and a ventilator rather than an NIV and a ventilator, or a NIV continue.
Yeah. So Dr. Indra Menon, yeah, can we add something? Yeah.
The COVID, I think the course was different. If you see the COVID ARDS as compared to other causes, I wouldn't bravely put an ARDS due to trauma or due to pancreatitis on NIV. I would go ahead and intubate. It was especially during the clinical course of COVID was totally different. If we saw many of our patients needed lesser PEEP. So that's why I think COVID made a special case for NIV. I think that's what I would say.
Yeah. Can I?
Madam, Dr. Indra Menon?
The PEEP with NIV is only 8 maximum. In the Patel study, it was 8, otherwise 5. So it's really not much of a PEEP. So those patients can easily be put on HFNO, where with the 60 liters, you'll get that PEEP, I'm sure. And it is more comfortable. But yeah, any deterioration, I guess we have to intubate. But because NIV, with the positive pressure in cardiac failure, definitely it's a useful mode. But in respiratory disease, as Justin was also saying, it won't go away in a day unless it's atelectasis. Then of course NIV may help. But it is we all use everything, but I think we have to be careful.
But I think during this COVID, we saw many patients recovering very fast over a few days, not 24 hours, but at least one lot of patients, we did see dramatic improvement over a few days as compared to other causes of ARDS. So
but they also improve with HFNO. Some of them with HFNO.
If HFNC is there, definitely, but if there's an increased work of breathing, I would consider giving NIV rather than HFNC.
So severe ARDS, probably obviously there is no role of NIV. Severe ARDS, yeah. Then another thing which is again thought-provoking was during the COVID time, some of the patients with 1 or 2 liters of oxygen, maybe early ARDS, technically they may be ARDS, and the patient used to some of the physiotherapy people used to give some kind of incentive spirometry and all. Some people in blanketly, unfortunately, sometimes there is a blanket advice of doing pranayama and all there. So basically, if the patient is already having an acute lung injury, those time, even if it's a mild injury, and you ask for pranayama, you ask for incentive spirometry also, if you tell the theoretical point of it is just going to increase the volume trauma, isn't it? Ventilator-induced lung injury is likely to be more actually in those kind of patients if you try to inflate the lung further in the stage of acute lung injury. Even in ward patients, those times, once in a while we just monitor during our medical emergency team and all. We used to monitor some of these patients are put on incentive spirometries and all. Probably again, there is one case for this effort-induced lung injury, because that time you need to give absolute rush to the patient. Dr. Justin?
There's a trial by Toshida et al. From Lauren Bouchard's group, and they believe that to eliminate all spontaneous breathing in ARDS patients. That is a bit extreme because that means more neuromuscular blockade and its own problems. But yeah, the shear stress comes down if you don't let the patient breathe too much.
Yes. And I guess that, and at the end of the day, it's a statement that Dr. Buna said, which exactly is true. So there are a subset of patients who do get better very quickly, And this is what we are unable to find. Recently, we were having a Bangalore group discussion as well. So the group of patients, because the COVID lungs seem to be so, the hypoxia is because of variety of pathologies, like, only pure ground glossing or a pure consolidation or organizing pneumonias or a typical H1N1 kind of ARDS or purely interstitial pattern. So we aren't, because of the widespread, disease process, we are not sure who's actually we're not going to be responsive to the NIV or not. That's become a bit difficult to choose at this point, and that's probably a good research question for the third wave.
It's over again.
Yeah.
Minutes will be over, I think. Yeah.
Yeah.
So thank you, Dr. Bhuvanekar, for the thought-provoking. So this is now open to anything from the audience.
I think quite a few questions have been answered, Ajit, and we could close the session.
Yeah. So I would like to thank once again all the participants of this PROCO debate. I would like to thank all the faculty. I sincerely thank you very much. Thank you all. I thank even Hallmark Events as well for providing this platform for this PROCO debate, and I especially thank the Micro Lab for sponsoring this session on a regular basis. So PROCO debate.
Thank you, sir.
Thank you all. Thank you very much. Thank you very much. Thanks. Thank you.